Welcome to week 7. We're already in for hematology. So this week we actually have 3 PowerPoints that we are going to go through. So we're just going to get started on those right away. So we're going to start first with it should be chapter 21, Anemia is caused by defects of DNA metabolism. So I actually want to start with this one first. Okay. I don't know why my thing's doing that. Okay. All right, so we're going to skip through the objectives. Sorry, I'm just trying to figure out something on my computer. We're going to skip over the objectives. You can read them later. But the whole premise behind this chapter is we're going to focus on a new anemia. And the anemia this week in this chapter is all about impaired DNA metabolism. So every cell in our body has DNA in it. And if you impair that DNA process, then you impair how we're making our cells in the first place, which is what is going to result in the anemia occurring. So, sorry, okay, there, I just had to clear something. Okay, so the whole principle behind this is that this DNA cannot be properly synthesized and created for our cells, thus you don't create cells. Megaloblastic anemia is the one that we are discussing in this chapter. So megaloblastic anemia, the whole root cause behind it is, again, impaired DNA synthesis. You will have very large red blood cells, so it's a macrocytic anemia, kind of like the name implies megaloblastic, it's macrocytic. So your red cells are large here, so you'll see that MCV be higher than 100. What happens to create megaloblastic anemia where they cannot create this DNA is that they are missing either folate or B12, or sometimes both. You need both folic acid and vitamin B12 in order to help make your DNA. If you are deficient in one of those, that's when this will result. So it's saying here at the bottom, folate, or you can say folic acid, is essential to production of thymidine nucleotides that are used in DNA production. It will go on to talk about how when they catabolize folate, which means break it down, they're going to need another source that is, another source is needed, which is 5-methyltetrahydrofolate. That's a mouthful, which releases, basically, in the end there, they need also vitamin B12 as a cofactor. So you can see the two together essentially are required in order to build and create DNA. So this is just kind of the whole principle behind it. To summarize it up in our terms, you need folic acid and you need vitamin B12 to have synthesis of DNA. And like it says at the bottom, if folate or vitamin B12 is missing, your DNA synthesis is impaired. As a result, you're not going to make cells. You won't make red cells, and you're not going to really make other cells either when you think about it. All cell lines are going to kind of be halted here. So that is what results in megaloblastic anemia happening. So we will see that when you're deficient enough, a little bit of a deficiency, not a big deal, but a lot of deficiency, that's when we're going to see an issue occur. So it'll kind of be one of two causes. The patient will either be deficient in folate or deficient in vitamin B12, or worst case, they might be deficient in both if they're not getting enough nutrients in. Of course, our clinical findings, what we're going to experience with the patients, same kind of symptoms of anemia, fatigue, weakness, shortness of breath. So those same anemia symptoms are there because, again, they're not making red cells to produce oxygen out to the body. With B12 deficiency, when that gets severe enough, that also has some neurological symptoms, such as memory loss, numbness, loss of balance. If folate deficiency gets severe enough, that can really affect your heart with cardiovascular disease. So there's some other things there because these are big nutrients for our body. We need them in many different processes. All right, so a little bit of causes. What would cause you to be deficient in one of these vitamins? For folate, and it's going to be really similar to vitamin B12, it's maybe you're just not getting enough in your diet. If your diet's only made up of like a soup and crackers, yeah, you're going to get deficient eventually in vitamins. And I've seen that happen, especially with elderly people or people that just don't have much of an appetite. If they don't take enough in, you're going to be missing some vitamins and you're going to become deficient. So inadequate intake, or it could be increased need if you're pregnant, impaired absorption if you're not absorbing what you are taking in properly or using it the right way. Any of those could result in a deficiency. So same with vitamin B12 here. There is a hereditary condition listed at the bottom. I'm not going to worry about that. It's just listed there that there are some hereditary conditions as well where you're missing it. All right, as far as lab, to diagnose megaloblastic anemia. So first and foremost, we'll do that CBC and get some CBC results. So with this, we are going to see pancytopenia. Pancytopenia is a term that means all 3 cell lines are decreased. So your white cell line, your platelets, and your red cell line are all low. That's going to indicate you're not making much cells. That's what we call pancytopenia. You're also, of course, going to see the aplastic anemia signs, decreased hemoglobin, hematocrit. Again, this is a macrocytic anemia, so your MCV will be high, so it'll be above 100. RDW is typically increased. Again, RDW is going to tell us there's anisocytosis present, those variation in red cell sizes. Your MCH is maybe sometimes increased, normal to increase, and MCHC can be either low or normal. That one can vary a little bit. It's typically normal, but I've seen it be low. When you look at the blood smear, you're going to find some interesting things on the blood smear. First and foremost, not only are you going to see those macrocytic red cells where they're larger, a lot of times they're what we call oval macrocytes. They're more oval cells in shape. That's not the same as elliptocytes. Elliptocytes are regular size and elongated that oval. Oval macrocytes are the large red cells in a more oval shape. They are different. And oval macrocytes really only belongs to 2 diseases. Megaloblastic anemia is one of them. We'll find another one later on. But oval macrocytes are a key finding. We will actually see hypersegmented neutrophils. So that kind of is described in a bullet down. Basically, when you have neutrophils, the neutrophil lobe count is typically 3 to 5 lobes in a regular neutrophil. What we consider hypersegmentation is any time that is more than 5. So above 5 would be considered hypersegmentation. So like 6 or more, if you will. I know it says 5 or more, but it's actually 6 or more lobes. So greater than 5 would be considered hypersegmented. And we really only see that with megaloblastic anemia. We're not real sure why that happens. It probably has something to do with that whole DNA synthesis being impaired and the way that nucleus matured, but it's not really quite understood, but again, it's very unique. So hypersegmented neutrophils where you have 6 or more lobes, very unique to being in megaloblastic anemia. We will see Dacrocytes. Those are teardrop-shaped red cells. Sometimes you might see some fragmented. You might see nucleated red cells because if you're low in all your cells, you might start to see the bone marrow release out immature ones. Howell-Jolly bodies. Last week, you guys completed a study guide on poikilocytes. Howell-Jolly bodies was an inclusion, so it's this little round inclusion that you might find in the red blood cells under the microscope. And if you did your chart on that, you should have wrote what it's made of. And Howell-Jolly bodies are actually made of DNA. So again, this whole thing is centered around impaired DNA synthesis as the cause, and you'll get these little DNA chunks inside the red cell known as Howell-Jolly bodies. So it's very much related to megaloblastic anemia here. All right, so lots of things that you might see under the microscope with this one. And then at the very bottom, it just discusses a couple chemistry tests where you might see an increased bilirubin and LDH, which is lactate dehydrogenase. These are things that kind of get released or seen anytime you have cells break down. So if we're seeing red cells get broken down early, we might see an increase in that. Not too worried about that here in this slide, so don't worry. I'm more worried about the other results that we went through. All right, so to diagnose it further, so if you start to see all those items on a CBC, you kind of have an idea you're dealing with a macrocytic anemia. You see oval macrocytes, hypersegmented neutrophils, Howell-Jolly bodies. You're starting to already figure out this is probably megaloblastic anemia, but you have to confirm it and diagnose it. So now, I've always said we don't right away jump to bone marrow, but if you were to do a bone marrow exam, you're going to see this really unique megaloblastic appearance of those red cells as they are developing. That is what the whole anemia is named for. And megaloblastic appearance basically indicates that we have a nuclear to cytoplasm asynchrony. That means We have learned the proper way that cells mature. As they mature, the cytoplasm gets less blue, it gets more pink, the nucleus gets smaller and sometimes changes shapes. That's the normal way. In megaloblastic maturation process, your cytoplasm matures at a normal rate, it's doing the right thing, but the nucleus lags behind, and that's because that's where the DNA is found, in the nucleus. And if your DNA is impaired, it's really lagging behind trying to get mature, trying to figure it out. So it looks very off. They don't look like they go together. Like your cytoplasm will look mature, but your nucleus looks like it's still back in the first stage. And so that's what we term a megaloblastic appearance to the red cells in the bone marrow. And that's kind of what they named the anemia for then. That M to E ratio 1 to 1, we're going to discuss that ratio thing in a minute in another PowerPoint, so I'm not going to worry about that here. But the real way, a better way to confirm this would be through blood tests, because a bone marrow exam is really invasive and we wouldn't really jump to that. So an easier way, if we're suspecting megaloblastic, is let's measure their folate levels, let's measure their vitamin B12 levels, and see what they are. We'll know right away if they're high or not high, if they're normal or low. And if one of them is low, that would be a clear indicator that, yeah, they have it. So those are easier to do. Those are simple blood tests. You could do a methylmalonic acid test. This is often performed if the vitamin B12 is low. It just kind of reflexes and just kind of verifies it. We don't need to go in depth to what it is. We're here more just to measure the folate and vitamin B12. There are other things that you could do, gastric analysis, antibody assays, things like that. So with the gastric analysis, under there, they talk about pernicious anemia. You probably have seen that term before. Pernicious anemia is a type of megaloblastic anemia due to vitamin B12 deficiency. Sometimes when people are deficient in vitamin B12, it is because they lack the intrinsic factor to help them absorb it. So it's an issue of absorption, and they can't absorb the vitamin B12 because they're missing an antibody to do that. So that's pernicious anemia. It is a type of vitamin B12 deficiency, so it all still falls under the megaloblastic anemia category. So the Shilling Test is the test that's really helped to determine is it pernicious anemia or some other type of malabsorption. So if the doctor is trying to figure out, okay, we see you're low in vitamin B12, are you low in vitamin B12 because you're just not absorbing anything really, or is it because it's specifically pernicious anemia where you are missing the intrinsic factor to absorb it? So they do this whole test, and I don't need you to understand all the details of the test, but just understand that there's like 2 stages. It's a whole urine collection process where they give them the vitamin, they screen the urine to see if they see the vitamin or if it was absorbed or not. So that's the whole process with the Shilling Test, is just to kind of confirm, is it pernicious anemia or is it some other malabsorption of why you're not getting vitamin B12? Because once the doctor finds out they're low in B12, they want to figure out, why are you low in B12? How can we make sure that we stop this? So, and then again, there might be parasites also causing them to be low in, say, B12 or folate. So once they figure out which one they're low in, they're going to treat that vitamin deficiency. If they're low in vitamin B12, it's really best to give shots. It's common nowadays for people to go and get B12 shots for energy. I hear a lot of people like to get them just for energy alone. Folate, you can get folate tablets given to you orally, and that will help start boosting up your levels. All right, so that is megaloblastic anemia. That's the only one that was in this PowerPoint in this chapter, all about DNA synthesis being impaired. So let us jump over to our next PowerPoint. We are going to do Chapter 17, Bone Marrow Overview. So it used to be Chapter 16, now I believe it's Chapter 17 in your new edition. So for bone marrow locations, when you're first born, almost all of your bones contained hematopoietic, what we call red marrow. That means it's actively producing cells. As you begin to get a little bit older through childhood, it will change, and so finally what ends up in adults is that the ends of your long bones will be the red marrow and the rest of it, the bone, will be yellow or fatty marrow. So that's kind of the picture. Whoops. Oh my gosh, there you go. The picture kind of shows that at the ends of those long bones are the red marrow. All right. So for when we want to go and collect a bone marrow sample, there are set sites that we do this, whether they're an adult or a child. So adults is typically the iliac crest, which is in your hip. Sometimes you can use the ribs or vertebrae, but usually it's the iliac crest. In children that are really young, it would be the front and middle of their tibia. The tibia is in the bottom part of their leg. All right, so when they go to collect the bone marrow, they are getting two things, an aspirate and a biopsy. The aspirate is just a really good sample to help determine the types of cells that are occurring in the bone marrow. And then the biopsy is going to let us, one, see the overall cellularity. Is it pretty cellular? Is there enough cells happening? How much cells to fat are occurring? And then it also allows for screening of different abnormal cells that might be seen in lymphomas and multiple myelomas, which is another type of lymphoma. Also, the biopsy is really necessary in times that you can't get the aspirate because of what we call a dry tap. So sometimes when you go into the bone marrow and try to get an aspirate, you get nothing out, and that's what we call dry tap. So in that case, we have to have the biopsy because we won't have an aspirate to look at. So a dry tap will occur due to one or two situations. Either one, there is no cells in there to pick up in an aspirate. It means they are so hypocellular, nothing in there, like in an aplastic anemia, and we're going to talk about aplastic anemia in the next PowerPoint. It was so hypocellular that nothing was picked up. Or case two, it was so cellular and so tightly packed you couldn't get them out of there, and that might be in the case of a leukemia. So kind of the opposite cases, but either one could result in you just not getting cells out in an aspirate, and then that's when you have to rely on your core biopsy. All right, reasons why we would do a bone marrow exam. Again, not required for anemia because there's lots of blood work, lots of other types of tests that we can do for anemia diagnosis. This is much too invasive, too painful, you know, for the patient to go through for a simple anemia diagnosis. We will do a bone marrow, though, when you are an adult or an older child, not a baby, but an older child or an adult, that you are seeing blast cells in the blood. Blast cells, again, are those really immature cells that should never be in your bloodstream, should only belong in your bone marrow. So if you're like above the age of, we'll say 1, and you get blast cells in your blood, that's a serious thing. We're wondering why you're getting such immature cells showing up. That's when they might go to a bone marrow. Let's see what's happening in the bone marrow. Is this a leukemia occurring? If we have a pancytopenia patient, again, pancytopenia meaning all 3 cell lines are low, red cells, white cells, and platelets, and we cannot figure out why they're low. We've investigated it. We've tried to figure it out. We tried to see if it was megaloblastic anemia, and it's not, you know, and you just can't come up with a reason why all their cell lines are low, then we'll go to the bone marrow. It could also be they know that they have a lymphoma, and we want to stage the type where they're at in their lymphoma, stage 1 through 4, kind of give an overview of that condition for them to help with the management of it. So again, only necessary for diagnosing and patient management of their disease. That is the reasons why we would do a bone marrow. So for the aspirate, an aspirate would be looked at first under low power, so like a 10x, and it will kind of look at the bone spicules that might be in it, which are little intact marrow segments. We're going to look at the overall cellularity. So again, cells to empty fat vacuoles, there should be a nice ratio there. You can also quickly screen the megakaryocytes. Remember, megakaryocytes are the cells that are going to make platelets. They're the biggest cells in the bone marrow, so they're easily seen under a 10x low objective. So we can just kind of see, make sure there's enough megakaryocytes, not too many, but enough of them around. Then you're going to move to your 100x oil immersion objective. And then this is where you're going to do a count. And what we are going to determine is our M to E ratio, our myeloid to erythroid ratio. So they're going to count around 500 cells in there. And they're going to make this. And they're going to classify those cells, either they are erythrocytes, red cell line, so they might be a pronormoblast, a basophilic normoblast, a polychromatic normoblast, or they're going to be under the myeloid line, like myeloblasts, promyelocytes, you know, those cells, monoblasts, promonocytes, those kind of things. So they are going to basically count those cells. They're not going to count anything in the lymphocyte line, and they're not going to count monocytes. I shouldn't have said the monocyte, but they're going to count the neutrophil line, the eosinophil line, the basophil line will all be counted. categorized under the myeloid side, and the red blood cell production line under the E, the erythroid. And they're going to determine the ratio. And a normal ratio is right around 3 to 1. So for every 3 myeloid cells you're making, you have 1 erythroid cell there. So that is a normal ratio for an adult. So it can vary. It can be like 1.5 to 1 to up to maybe 4 to 1 is all normal. So when that varies, though, that ratio, if that varies, that is an indicator that, wait, some cell line isn't right here when that ratio gets away from those numbers. So that is the MTE ratio. It's something that's always done on a bone marrow sample, and it right away gives us an indicator of what is the cell production going on in the bone marrow. What I should say before I move off of that, and you will see this in different case studies. I'm going to actually adjust this to back here because I want to write. So again, an MTE ratio can be anywhere from 1.5 to 4 to 1, so meaning that there are always more myeloid to erythroid cells. So in a case study, if you ever see a 1-to-1 MTE ratio, where all of a sudden you're equal in the amount of cells you're making on both sides, that tells us that you have increased your erythroid production. Sometimes people get that confused and think, oh, you've decreased your myeloid production. No, you have increased your erythroid production. So before, you were making way more myeloid cells to every 1 erythroid. If you pick up your erythroid production, now you're equally making the same amount of cells on both sides. So a 1-to-1 often indicates you have really increased the amount of erythrocyte line that you are making. So I just wanted to point that out because sometimes that's really confusing to people. So, all right, let me go back to the PowerPoint presentation. All right. Other things that, again, we look at, we already discussed the megakaryocytes, that they're the largest cells. We're also going to look at the bone marrow cells themselves, the osteoblasts and osteoclasts. We might look at the fat cells, adipocytes, endothelial cells. You can quick view them. Make sure that you're just kind of scanning around, making sure there's no tumor cells, there's no bunching of cells in a cluster. That's often indicating tumor-like cells happening when they bunch together and cluster. So on to the core biopsy. So again, the core biopsy gives you an actual intact portion of the bone marrow. Again, you can do the cellularity, you can do the MTE ratio here because a lot of times we might not get an aspirate. You can look at iron storage. If you were to stain the core biopsy with Prussian blue stain, that would show you the iron granules and how many there are stored in there. So these are all different things that can occur off of a bone marrow. So basically, we just really want to take into account all cell lines. How is the production going? Are we producing enough of them? Are we producing not enough? Are there any abnormal cells present? You know, things of that nature. Just getting a really good overview of a bone marrow. All right, so that is just a rough overview of the bone marrow and the necessity behind it. Now let's jump to our last PowerPoint, which is Chapter 22. Again, I think it was Chapter 21, but now it's Chapter 22, which is on bone marrow failure. So bone marrow failure is any time that at least one cell line in your bone marrow is not producing anymore. So it doesn't mean that all cell lines have failed. That is possible, but it means at least one cell line has stopped producing their cells. Most of the time when we see bone marrow failure, we do see pancytopenia where all 3 cell lines are low. And a bone marrow failure can occur due to, oh my gosh, so many different things can happen to make a bone marrow failure. It could be that you picked up a virus. It could be different chemicals, radiation, autoimmune, you know, kind of things. Things like if you're really deficient in vitamin B12 and folate and stem cell mutations, things like that. So this just kind of goes on and lists all the different types of bone marrow failure mechanisms. They're not memorizable. They're just, you know, reference. All right, so clinical significance, what happens to you when your bone marrow does fail? Well, let's think about what we know our cells do as a job. So first and foremost, let's start with platelets. We know that platelets' role in our body is to form clots. If you have thrombocytopenia, meaning low platelet count, you're going to now be prone to bleeding. You're not going to make those clots anymore. You're going to have probably bleeding issues, especially if they get really low. If you are low in your red cells, again, red cells carry your oxygen to your tissues, to your organs. If you are low in red cells, you're not going to get that oxygen to the tissues. And as a result, you'll see the anemia happening with fatigue, pallor. Your heart's going to start beating and trying to pump out more blood, trying to get anything out there, so leading to heart problems. And then white cells. White cells was all about defending your body against infection. So if you were to stay low in neutrophils, a neutropenia, you're now at risk at bacterial infections and not being able to fight them off properly. So as you can see, if you're low in any of your cells, if you think about what that cell line job was, now it can't do that job anymore, and then that's what puts your body at risk. So aplastic anemia is probably the first bone marrow failure syndrome here that we're going to go through, and one of the bigger ones to discuss. So the word aplastic really means without. A always means without. So we are without cells in this. And so it is a bone marrow failure that has resulted from damaged stem cells. So stem cells, if you damage them or they're defective, you're not going to produce cells at all. That's just the nature of it. We know that from learning our hematopoiesis charts. You don't make the stem cell at the top, you can't make any of the cells at the bottom. So of course we're going to see pancytopenia, all cell lines decrease. And of course that includes reticulocytes. You will see low reticulocyte count. You can't make those if you can't make any cells. In the bone marrow, when you look at a bone marrow exam, you should see a very hypocellular bone marrow. So lots of fat patches and very little cells. So aplastic anemia can be acquired or it can be inherited. So first, the acquired, most of the time we have no idea why somebody picks up an acquired aplastic anemia all of a sudden. It's usually what we say idiopathic, unknown. Sometimes we've been able to link it to different drugs, radiation, things that they've been exposed to, but again, most of the time we're not sure. So this is just thoughts of what could be linked with it. All right, so again, primary reason behind acquired aplastic anemia is a defective or deficient stem cell. We can count somebody's stem cells with an analyzer by looking for their CD34 antigens on the surface. That's in bold there for a reason. CD34 is the cell marker that identifies stem cells. And so if you put the sample through a flow cytometry analyzer, it will count for those CD34 markers, and you can get a number back. It will tell you you have this many hematopoietic stem cells, because again, we can't see those stem cells under the microscope, so we got to rely on an analyzer to count it for us to know how many they have. And when you get that count back, you're going to see it's low in aplastic anemia. There's not enough of those stem cells, which is helpful to diagnose that it's aplastic anemia. Actually, for the bone marrow itself, otherwise, besides the abnormal stem cells, it's pretty normal in its growth factor production. So there's not anything an issue there. It's all just due to the damaged stem cells. All right, so the depletion of those stem cells could be due to either a direct mechanism from a drug, a chemical, radiation, or virus, or it could be due to an indirect mechanism, such as exposing somebody that's really susceptible and then they have an autoimmune attack. You do not need to know this slide. It is just informational. All right, clinical findings. So it is an anemia, same symptoms there, pallor, fatigue, weakness. If you get low enough, you're going to see some heart problems because your heart's trying to compensate by putting out more blood. If you're low in platelets, you're going to see different bleeding signs. So petechiae, bruising, epistaxis, which is a nosebleed. Epistaxis is nosebleed, I can't say that. Bleeding gums, so on. So you get the idea of bleeding due to low platelet counts. And again, if you are low in neutrophils, you're going to be prone to infection, so you might see a fever occur when somebody does pick up an infection. For lab findings, of course, under a CBC, we are going to see that pancytopenia. All three cell lines are low. We're going to see low hemoglobin, low hematocrit, indicating the anemia. MCV typically is normal here. It's a normocytic, normochromic anemia. Sometimes it's a macrocytic anemia. So just once in a while, it might fit into that increased MCV category. Typically, we put it under the normocytic category. Again, reticulocytes will be decreased because you can't make cells at all. Ignore the toxic granulation. That's something that we'll talk about further down the road. That might be in heme too, so we're going to ignore that for now. As far as iron goes, you are going to see a lot of iron available in the bone marrow. If you were to stain it with Prussian blue and look for iron, you would see a lot of it, and that's because we're not making red cells, so we have all the iron available and just not being used. It's just sitting there waiting. So you're actually going to have quite a bit of iron. And then, again, you're going to see mostly fat cells in your bone marrow with patchy areas of low cellularity. Treatment, if you can figure out what's causing their acquired aplastic anemia, you know, discontinue that. If it's an exposure to a chemical or drug they're taking and their body's reacting weird with that drug, stop it, you know, discontinue its usage. So that's if you can figure it out. Otherwise, in the meantime, let's support and give them cells. So we'll give them platelet transfusion. We'll transfuse red cells. We can transfuse granulocytes. We can try to up their numbers by transfusion products to help keep them going. If they are young enough, then we might look at a hematopoietic stem cell transplant to give them nice, healthy stem cells. If they're not that young, if they're an older adult, then we might look at more immunosuppressive therapy and things like that to just kind of try to maintain them. All right, that was all acquired aplastic anemia. For the inherited form of aplastic anemia, that is known as Fanconi's anemia. It is a recessive disorder. So again, you're going to see all those same signs and symptoms of aplastic anemia here within Fanconi, along with a couple other congenital abnormalities. So you would see skin pigmentation, short stature, and hypogonadism all go along with this as well. So I do need you to remember Fanconi anemia and the bolded part there of what kind of signs indicate this inherited disease. So basically, what does it say here? 90% by age of 30 will have full-blown bone marrow failure. Sometimes if they have it sooner, they might see death by age 20 from complications. So it's a severe illness. It's a severe condition. So that is Fanconi. Make sure you know it's an inherited aplastic anemia characterized by skin pigmentation, short stature, and hypogonadism. Another inherited one is Dyskeratosis Congenita. This one is pretty rare, but I still need you to know it, and I would know that it is, besides the classic aplastic anemia signs with bone marrow failure, pancytopenia, we are also going to see abnormal skin pigmentation, dystrophic nails, and oral leukoplakia. Oral leukoplakia is like white patches in the mouth. So those are the three that I would really connect back to the Dyskeratosis Congenita. The way that I remember this one is the dystrophic nails, you need keratin in your nails. And if I look at the word dyskeratosis, I remember that caret part as indicating nails. And so that's how I link it together. I think on one of your tests, these are short answer questions, where I give you the characteristics and you have to type in the disease name on a future exam soon. So I would start really getting to know this. I don't expect you guys to be spelling experts, but type it as close as you can so I understand what disease that you were indicating. So if I were to say to you guys, abnormal skin pigmentation, dystrophic nails, oral leukoplakia, I want you to be able to type in it's Dyskeratosis Congenita. So this one, again, very severe. Death usually occurs before age 20 due to such bone marrow failure. All right, other types of bone marrow failure now. So now we have ones that maybe are affecting just one cell line, starting with pure red cell aplasia. So this is only affecting the red cell line, just like the name tells us, pure red cell aplasia. So basically means without the red cells. So only that line is being affected here. Otherwise, all the other lines are healthy. They're normal. So your granulocytes, lymphocytes, platelets are all fine and normal. So everything that you see lab-wise is going to be due to the red cell line not getting produced. So severe anemia, reticulocytopenia, but otherwise the rest of the cells are normal. So that's overall pure red cell aplasia. Now there is an inherited form called Diamond-Blackfan anemia in which the stem cells get defective. So I would know that Diamond-Blackfan anemia is an inherited red cell aplasia. Congenital Dyskeratosis Anemia is another one that only affects the red cell line. So the middle word, erythropoietic, tells you it's all about the red cell line. So this one, you are going to see really bizarre things happen to your red cells as they're trying to make them. They're going to be very giant red cells, multiple nuclei in the red cells, so they're just really bizarre. They're not properly made cells, and that's where the erythropoietic term comes in. I kind of think of it as dysfunctional erythropoiesis, dysfunctional red cell production, resulting in these weird changes in the red cells. So that one you do need to know and be able to write out. Myeloproliferative anemia is where you have abnormal cells coming into the bone marrow, destroying and replacing your normal cells that were there. A lot of times we might see this with different tumor cells or leukemia cells. So they're coming in, getting rid of the normal cells that once were there. So that is myeloproliferative anemia. Anemia of chronic renal insufficiency. If your kidneys aren't working properly, then you're not going to make erythropoietin hormone. If you can't make erythropoietin hormone, you're not going to produce red cells. So this is a bone marrow failure of the red cell line because you're not producing erythropoietin hormone to make the red cells that are needed. So that is anemia of chronic renal insufficiency. All right, so there is quite a few diseases at the end there. I do need you to be able to type those answers out on an exam if I were to give a short description. You don't need to know everything about each one of those at the end, just the very key characteristics of it. What I basically read off to you on each one toward the end there is what I need you to know about it. I mean, just a very key description, and that's it. You don't have to be experts on all of those at the end. So that should be it for this week. As always, if you guys need anything, just please feel free to email me and we can chat. Have a great week. Thank you.